which does a huge amount for women and supporting research. And in my view, Kipros has done more for women's health than anyone else in living memory. So, Kipros, it'll be great to hear you talk about preeclampsia. Thanks.
Thank you very much, Steve, and thank you for organizing these webinars. Steve started off last year by having a local meeting in his own university. And these meetings were very popular. And he came to me a few weeks ago and he said, why don't you open them up? And I said, of course, Steve. And they are proving to be very popular. So I will talk about prediction and prevention of preeclampsia, which is my field of interest for the foreseeable future. And I start off with this slide, really, this beautiful American gold medalist, or Olympic gold medalist, Tori Bowie, who died at the age of 32 last year from preeclampsia 32 weeks in her pregnancy. And of course, preeclampsia is causing the death of more than 75,000 women every year and more than 500,000 fetal and neonatal deaths. So it is a condition that is important. In terms of trying to identify the high-risk pregnancies, we have different methods. And the most commonly used method is that of risk scoring, where we ask women a few questions: previous preeclampsia, chronic kidney disease, chronic hypertension, diabetes, or autoimmune disease. And if the answer to any one of these questions is yes, then you are told you are at high risk. If the answer to all of the questions is no, then you are asked 5 more questions. And then if 2 of the 5 is yes, then you are also classified as being at high risk. It's a very good method because it doesn't cost anything. We simple-minded obstetricians can just about remember these 10 different questions. But the real question in terms of screening is, how good is it? Well, I'm reminded of another method of screening in pregnancy, and that is screening for Down syndrome, where about 50 years ago, we had an equally simple method of asking women, how old are you, dear? And if you were over the age of 35, you were told to have an amniocentesis. At that time, the performance of screening for Downs by this, how old are you, was characterized by a screen positive rate of 5 to 10%, and a detection rate of about 30 to 40%. Well, unfortunately, this is exactly where we are today in screening for preeclampsia, as we used to be 50 years ago in screening for Down syndrome. And yet, 30 years ago, we realized that if in addition to asking the question, how old are you, you also did an ultrasound scan at 12 weeks, and you measured the nuchal translucency, and these are images from 1992, which show that however bad the ultrasound machines were, we could still realize that the bottom fetus had a much bigger black space behind the neck than the top one. And then you combine that information with biochemistry, suddenly the detection rate went up from 40 to 90%, and the screen positive rate went down from 10 to 5%. And the question is, can we do the same in screening for preeclampsia? And the answer is yes, we can. We can ask a series of questions, and that gives you the starting risk or the prior risk. Then you do some tests, and then you modify the starting risk, and you get the posterior risk. And this is exactly what is illustrated in this slide. The risk increases with maternal age and weight. It is higher in Black and South Asian women than those that are white, in those with previous preeclampsia, if the mother had preeclampsia, if they conceived by IVF, if they have chronic hypertension, diabetes, and autoimmune disease. And that gives you a starting risk. Then at the time of the 12-week scan, you look at the uterine artery and measure the pulsability index. You measure the mean arterial pressure and the placental growth factor. And in a head-on comparison in 7 hospitals in England, involving nearly 17,000 women, the triple test is this blood pressure, uterine artery Doppler, and PLGF, had a detection rate which was exactly twice as much as that of using the risk scoring system. And therefore, it was clear for me that that is, or should be, the end of the story. But you know, in 1992, when we were advocating the combined test for screening for Downs, nothing very much happened for another 15 years. And it is possible that the same may also happen in terms of screening for preeclampsia. The next question is, how accurate is this assessment of risk, and how reliable it is? And to answer this question, we do this sort of graphs, where on the x-axis we plot the predicted risk, and on the y-axis the observed incidence of whatever it is that we want to test. If we take 100 women and we tell them that your risk of having a Downs baby is 1 in 2, then at the end of the pregnancy, about 50 of these 100 women should deliver a Downs baby. And if we take another group of 1,000 women and we tell them the risk is 1 in 1,000, then at the end of the pregnancy, 1 in these 1,000 women should have a baby with Downs. So if we plot on the x-axis the predicted and the y-axis the observed, we should have a perfect diagonal blue line, which combines this predicted and observed incidence of a disease. In this study of nearly 36,000 women, the interrupted black lines had a near perfect agreement with the blue ones. In another multi-center study across various countries in Europe, nearly 9,000 women, the same was true. In this head-on comparison of different hospitals in England, again, a very good agreement. A study in 5 different regions in Spain, again, very good agreement. 7 different Asian populations from Hong Kong to Japan to Vietnam, very good agreement. And then 5 hospitals in Denmark, a very good agreement between prediction and observation. So the condition, the methodology is validated, it's accurate, and it's reliable. The next question is, when we are clinically implementing something, how do you do that? Well, England has a lot of good experience on doing that in terms of screening for Down syndrome. From the very beginning, when screening for Downs was implemented, one person called Professor David Wright, a mathematician in the University of Exeter, has been given the responsibility of receiving the results of nuchal translucency from each sonographer in each hospital in England, and the biochemical results from each laboratory in England. And he just looks at these results. He is unable to know who these people are, and he doesn't really care. He just plots their results. And if the results fall in the green zone, he sends them a letter telling them, well done. If they fall in the yellow zone, he tells them, you're not too bad, but be careful. And if the results are in the red zone, he sends the police to stop that hospital from mismanaging their patients. And that's how it should be, until they find the reason for the wrong results. And this can also be implemented in screening for preeclampsia. Blood pressure, Doppler, and placental growth factor should follow the same pathway. It was very interesting, really, where we looked at the results from King's and Medway, the 2 major hospitals that contributed to these studies. We were getting completely different results in blood pressure, and you couldn't understand why, until we realized that the blood pressure measurements at King's were done by research fellows, doctors, that scare patients, and they're very quick. They don't really want to waste 5 minutes measuring a blood pressure. And therefore, they were recording the first measurement, and it was always high, whereas in Medway, it was auxiliary nurses that were measuring the blood pressure, and they were obeying the rules of waiting for the women to relax, taking one set of measurements from the left and the right arm, waiting for an extra minute, and repeating the measurements. And therefore, all their measurements were lower. So it is very important that these results are examined and adjusted accordingly to give accurate results. The next question is, do we really need to do the triple test in all patients? To answer this question, we looked at these 60,000 women. The triple test is the red line, blood pressure, Doppler, PLGF. And if you do that, you have a detection rate of 90% of early and 75% of preterm preeclampsia. If you're in a poor country like England and you cannot afford to measure PLGF, which costs about £5 per patient, then you do the double test. Or if you are in the United States, where they have money, but they cannot do Doppler for one reason or another, Then you do another double test, blood pressure and PLGF. What do you lose from doing this double test rather than a triple test? Nothing much, really. You have a lower detection rate of early by about 10 points and preterm by about 7 points. This is identical to the situation in screening for Down syndrome. The detection of nuchal plus biochemistry is 90%. If you don't have money to do the biochemistry, you just do the nuchal, and the detection rate is 80%, which is still a lot better than just the risk scoring system. But there comes another story, really. When we were screening for Down syndrome, if you were screened positive, you had to have an invasive test which could kill the baby and or the mother. So you wanted to keep the screen positive rate as low as possible. When we introduced screening for preeclampsia, I was influenced by that ideology, and I wanted to keep the screen positive rate as low as possible. But that was not necessarily logical, because the implication of being screen positive is not to have an invasive test, but it's just to take aspirin. So what do I mean by what I'm saying now? Is this: if you do the triple test and your desired detection rate is 75% of preterm, then you can achieve that by classifying 10% of your population as being screen positive. But if you're poor and you can only do the double test, well, it's not a big deal. You can still achieve a detection of 75%, but at the expense of a screen positive rate of about 14 or 15%. The next question is that, does it matter whether you're black or white? In a politically correct era where we are afraid to open our mouth anymore or even look at people, it is meant to be a bad thing to ask people about their ethnicity. But in failing to do so, we are biasing our method of screening against the very group that we don't want to ask their ethnicity. What do I mean by that? The risk of developing preeclampsia if you're a black woman is 3 times higher than if you're a white woman. So if you live in a multi-ethnic society and you set the risk cutoff at, let's say, 1 in 100, in the white segment of the population, the screen positive rate would be 10% and the detection rate 70%. But within the same population, for the same risk cutoff, the screen positive rate for black people is 34%, and the detection rate is 92%. Are you surprised by that? Of course not, because they have a much higher risk to begin with in any case. Now, I say because of these results, you live in a predominantly white society, perhaps we should be using a risk cutoff of 1 in 150 to improve the detection rate to about 80%, even if that means that the screen positive rate is 16%. The next question often in some research applications or grant applications is that we should be focusing our attention to women that are nulliparous. Because if you had a woman that had a previous pregnancy and they developed preeclampsia, you say, well, they're at high risk anyway. And if they had a previous pregnancy and they did not develop preeclampsia, you say, well, they will not develop preeclampsia again. Is that true? As usual, the true statements are false. We looked at this population of 60,000 women, and this is the contribution of the different components of the population to preeclampsia. The nulliparous women, which are about half of the population, contributed 55% of those that developed preeclampsia. Those that had no previous preeclampsia contributed 30% of the preeclampsias in this pregnancy. So to say that because you had a previous pregnancy without preeclampsia, you are safe, it's completely false. The next question is prevention of preeclampsia by aspirin. And then I want to take you through this first slide slowly so that you can understand how we grow up in medical schools, in universities, in medical practice around certain myths. And one of the biggest myths in medicine, as far as I am concerned, is that what comes out of the Cochrane reviews is the ultimate truth, especially if it arises from the ultimate level, so-called, of medicine called meta-analysis. I often refer to meta-analysis as spaghetti alla carbonara in an Indian takeaway with a Chinese cook and a Greek waiter. They just throw everything in the pot and they start mixing them around, and then they come up with an incomprehensible for me result, but that becomes the ultimate level of medicine. Let me show you how we acquire this ultimate level of medicine. A very respectable group of researchers looked at 60 trials on the use of aspirin versus placebo. The number of patients in each one of these 60 trials varied from a lot less than 100 patients to more than 1,000. Actually, nearly 90% of these very important trials recruited less than 1,000 patients. And then let us look at the indications for these trials. Abnormal uterine artery Doppler, high risk of preeclampsia, chronic hypertension, or previous preeclampsia, high risk or established fetal growth restriction, PCOS, IVF, positive rollover test. Do you know what is this rollover test? It means that when you wake up in the morning, if you turn around in the bed and you fall out, you are positive. And if you stay in the bed, you are negative. And then multiple pregnancy, 7. Completely heterogeneous numbers, heterogeneous groups of indications, and then let's see how they treated these women. In some trials, they didn't give aspirin at all. They imagined that they would give aspirin. In others, in the vast majority of studies, they gave aspirin ranging from 40 to 100 milligrams, and very, very few gave the proper dose of 150 milligrams. And then let's look at the right. The right shows when do you start giving the aspirin and when do you finish? Or for how long do you continue recruiting patients? Well, some of the studies recruited patients when women were on the trolley to be taken to the operating theater to have a cesarean section, hoping that by giving them aspirin, during the next 10 minutes, they will prevent them from developing preeclampsia during delivery. It is absurd, really. 0 weeks to 34, 36, 38 weeks. Very, very few studies actually gave aspirin starting before 16 weeks. And one of the panelists today is Emmanuel Boujol from Canada, who first looked at this point and he said, this is absurd. We need to look at the studies that gave a proper dose of aspirin starting early in pregnancy and then to see what is the effect. And the effect was not 10 to 15% reduction, but substantially higher. And that was the basis for this trial, the aspirin trial. We took 27,000 women, we screened them properly with a triple test. We identified the high risk group at 12 weeks, and we gave them 150 milligrams of aspirin from 12 to 36 weeks. And it was fantastic. We reduced the rate of early preeclampsia by 90%, preterm preeclampsia by 60%, but we did not have an effect on the incidence of term preeclampsia. What is perhaps more important is this study. In most countries, the cost of obstetrics is minimal by comparison with the cost of neonatal intensive care. And the main reason why you stay in hospital as a neonate is because you were born before 32 weeks. But if screening can identify 90% of the women that will develop early preeclampsia and aspirin prevents 90% of those, then inevitably you will substantially reduce the number of babies that are born before 32 weeks, and inevitably the cost of neonatal intensive care. In England, it costs at least £2,500 a day for neonatal intensive care, and many babies born before 32 weeks stay in hospital for a long time, and the total cost for them is more than £100,000. And if we look at the total cost to the country of looking after individuals that were born very prematurely, because many will end up being handicapped, then it is about £3 billion per year. There's another question. And that was raised by a very good guy from Spain, that is a rising star as far as I'm concerned, Manuel Mendoza. Manuel Mendoza said that, but we really need to carry on giving aspirin to everybody for a long time because we may have hemorrhagic events. Can we not measure the placental growth factor and fleet? And if they have normalized at mid-gestation, then we can stop giving them aspirin. It's logical, although there is something false about the argument. Maybe the very group that is responding to aspirin is the one where you have normalization of the biochemistry, whereas the ones that are not responding to aspirin, they don't have normalization. Maybe, therefore, we should continue to give aspirin to those where you have normalization and not give aspirin to those that do not have normalization. In any case, this is the study that they conducted in about 1,000 women, and they randomized them into those that stopped versus non-stopping aspirin amongst those that had normalization of the fleet to PLGF ratio at 24 to 28 weeks. And there was no significant difference in the incidence of preeclampsia between the two groups, and they said, therefore, the point is proven. However, unfortunately, that was impossible because the number of cases recruited into this study was extremely small. And therefore, we suggested that if you really wanted to find out the effect of aspirin, you needed to study a much larger number of the population, not less than 1,000, but more than 15,000. So we agreed that we should conduct a study to address this question. And let me take you through the graph on the right, because that is very interesting. If you take a screen positive rate of 10%, then the detection of preterm preeclampsia is 75%. If we go for a screen positive rate of 30%, we will be picking up 90% of preterm preeclampsia, and we will increase also the detection of term preeclampsia from 40 to 71%. So the study we are proposing to do is to screen people at 12 weeks and give aspirin to the top 30% of the population, and then randomize them into two groups, one group that we stop the aspirin at 20 weeks and another where we continue. We will not be affected by the fleet and PLGF, and at the end of the pregnancy, we will look back and see whether there was any difference between stopping and non-stopping. After all, the story goes that aspirin perhaps works by improving the second wave of invasion, which is completed by 20 weeks anyway. And then we will see whether it makes any difference or not. And if it does make any difference, whether the group that should be continuing the treatment are the one with normalization or not of their biochemical and biophysical results. Let me address another question that arises from this magic called the ultimate level of medicine, and that is calcium. A good group of people, researchers, have taken 13 studies, and they have repeatedly, as if they were in need of improving their CV. Every 4 years, they were writing another paper and another paper and another paper on the same 13 studies. And I found that incomprehensible. But I was not surprised that the WHO, half of the group were also in this WHO committee. They recommended that people should be taking calcium because it is really good in reducing the rate of preeclampsia. And it was Steve that raised the question to me, because he's a basic scientist in terms of how calcium perhaps would be working, that said, but there's no real mechanism in which calcium would be beneficial. But anyway, so we looked again at the evidence. Well, this is the 13 studies. Villar, great man, professor of epidemiology in Oxford now, 8,500 pregnancies, no effect of calcium. Levine, one of the greatest Americans, the very person that wrote the New England Journal of Medicine paper, which highlighted the changes in fleet and PLGF in women that develop preeclampsia. 4,500 women, no effect. And then Nir Romanesh from Iran, 30 patients. Lopez Jamarillo, 50 patients. Lopez Jamarillo, 100 patients. Lopez Jamarillo, 250 patients. And then somehow you take this data of thousands and thousands of patients And you mix it up with the 30 and the 50 patients, and you come to the conclusion that calcium is fantastic. We looked at this, and we looked at the three biggest studies that accounted for more than 90% of the total evidence, and there was no effect. And then you have the silly studies that are highly heterogeneous, where if they are so heterogeneous, you're not allowed to put them together, but they do put them together, and they do publish them in the Cochrane Review, and they do create a WHO policy, and they say that calcium works, and of course it does not. Let me now go to 20 weeks. Is it now enough that we finish to the first trimester? And the answer, of course, is not, because there's still a lot of preterm preeclampsia that we missed, and there's a lot of term preeclampsia that we have not even addressed. So at 20 weeks, when we see women again, we can reassess the chances. And then if their risk is very, very high, then we have to give them a blood pressure machine home to check their blood pressure. And if their risk is low, we see them all again at 36 weeks, because I think that all women should have 3 routine ultrasound visits in pregnancy, 12, 20, and 36 weeks, to diagnose and diagnose breech, serious abnormalities, big and small babies, oligohydramnios, polyhydramnios, and also to assess the risk for preeclampsia. The number of patients that will be seen in each one of these different stages, because they were identified as being at high risk, will depend on the method by which we assess the risk. A good biomarker, believe it or not, of preeclampsia is the estimated fetal weight at 20 weeks, because a hell of a lot of babies in women that develop early preeclampsia are small, and therefore being small at 20 weeks is a good marker of subsequent prediction of development of preeclampsia. Estimated fetal weight, history, and uterine artery Doppler can identify the majority. And if you have money and you measure PLGF also, then the number of patients that you need to follow up is reduced. Let me address the question of term preeclampsia now. Everybody knows that if a woman develops preeclampsia at 28 weeks, the baby is going to be very small. If you deliver them, the baby may die. If you keep them going, the woman may die. But if you have a woman that develops preeclampsia at 40 weeks, who cares? All you need to do is deliver them and nobody dies. Is that true? Well, what is true is that the incidence of severe hypertension, maternal death, perinatal death, and so on from preterm preeclampsia is much higher than that of term preeclampsia. But if you're on the left, the incidence of preterm preeclampsia is much less than that of term preeclampsia, and therefore the contribution of term preeclampsia to adverse events is quite substantial. And actually, the majority of adverse maternal events are due to term preeclampsia. And we do have a problem, don't we? First trimester screening identifies only 40% of term preeclampsia. Aspirin prevents only nothing much of term preeclampsia. So what can we do? Well, screening at 12, 20, and 32 weeks identifies a proportion of the term preeclampsias, but if we really want to identify the vast majority of term preeclampsia, we need to screen at this magical 36-week assessment, where the method of screening is mean arterial pressure, placenta growth factor, and FLIT, and then we identify about 75 to 80% of term preeclampsia. And then what do we do? Well, we tortured ourselves with a study involving 30,000 women at 36 weeks, identified a high-risk group, and we gave them either pravastatin 20 milligrams per day or placebo, and unfortunately, we failed to show any impact in the prevention of preeclampsia. The next study we did was this. We assessed the risk for each woman, and on the basis of their risk, we stratified them into when to deliver. If their risk was extremely high, like 1 in 2, which was only about 1.6% of the population, we said, we will deliver you at 37 weeks. And then less risk, 38, 39, 40, and so on. And it was a very, very simplistic and simple way of thinking. If you find somebody that is meant to develop preeclampsia tomorrow, and you deliver them today, well, you will have prevented them from getting preeclampsia unless they get postpartum preeclampsia. We did this study, 8,000 women randomized into revealing the results of their risk and timing the birth, and the group where we were not assessing their risk. The rate of term preeclampsia was reduced by 30% without the feared increase in cesarean section or neonatal intensive care. So that was a good conclusion. Let me now finish in the next 10 minutes some of the useful biomarkers that you can use at different stages in pregnancy. First trimester, blood pressure, uterine artery Doppler and placental growth factor. Second, third trimester, blood pressure is always logical because preeclampsia is a disease of blood pressure. Uterine artery Doppler, not particularly useful in term preeclampsia. Placental growth factor, always useful. Fleet goes up only 3 to 5 weeks before the clinical onset of the disease, so it's not going to be useful. The next question is this continuing debate about the cardiovascular system. We took nearly 5,000 women during their routine 20-week scan, and we did a full maternal echo. The black vertical line on the right is from normal pregnancies, and the horizontal black lines are from women that subsequently developed preeclampsia. And more or less, the cardiovascular system was normal at 20 weeks in those that would develop preeclampsia, except one thing, and that is peripheral vascular resistance. I feel that most probably women that will develop preeclampsia, perhaps even before they even think of having sex, let alone getting pregnant, may already have a degree of vasculopathy with increased peripheral resistance. That is why they develop preeclampsia, and that is why they will continue to have an increased risk of long-term cardiovascular disease. But who is going to be doing maternal echo on everybody at 20 weeks? Well, can do something else. Watch this now. Watch the video. You finish the scan, you put a bit of gel on the transducer, you ask the woman to close her eyes, put the transducer over the orbit, and then there's a big black blob. That is called the orbit. You put the color on, and there's only one vessel, and that gives you a very special waveform. There's one peak in systole, the heart contracts, blood is squirted up into the internal carotid artery, and then the ophthalmic artery, and then the wave of blood goes to the periphery, it hits the small arterioles, and then it is reflected back into the heart and into the brain. The second wave, therefore, is a reflection of peripheral vascular resistance. We have done studies at 36 weeks, 9,000 women, 20 weeks, 12 weeks. The blue horizontal lines are from normal pregnancies. The red circles are from women that subsequently developed preeclampsia. And a few days, a few weeks, a few months before the development of preeclampsia, you have this evidence of increased peripheral resistance. And unlike the uterine artery, where there are all sorts of colored vessels floating around in the pelvis, in the case of the ophthalmic artery, it is much easier to learn and do. Indeed, I have given 14,000 waveforms to a mathematician from Germany, and he looked at the waves. He said, Kipros, with artificial intelligence, whatever that means, we can now look at this waveform, and it is much better than the measurement of PLGF and fleet and even blood pressure in the subsequent development of preeclampsia. So I will finish the lecture now by showing again this woman that died as a result of preeclampsia. It's a condition that kills women and babies. And it's a condition that, to a great extent, we are able to now identify the high-risk group, and with various measures. In the first trimester, giving aspirin. In the third trimester, timing their birth, reduce the incidence of the condition. So thank you very much. And Steve and the other panelists, I can see there, we can have a discussion.
Thanks. That was just amazing.
Ranjit and Themis.
Thanks, Kipros. Just amazing as always. And I just love the way you say, we thought this, so we did a study on X thousand patients when most of us struggle to get a few hundred into a clinical study. So absolutely amazing. And real hope in terms of the ophthalmic artery Doppler. I think those results are absolutely fascinating. And I suppose, how do we move that forward and bring it into practice? I'm going to open up to the other panelists in a second. I'll just ask a couple of questions. There's been quite a lot of questions online from various people asking when to start aspirin, how much, and when to stop it. So if you could just give one sentence summary to those that are asking those questions, and then I'll ask something, and then I'll open it up if that's okay.
Well, we started when we screen, and the screening is effective because that's when we did the studies at 11 to 13 weeks. The dose is 150 milligrams, and we stop at 36 weeks, unless the planned new study suggests that you can stop at 20 weeks.
Thanks. And my question is about the mechanism and the fact that aspirin doesn't work in all women. Does that tell you something about the mechanism of that preeclampsia? Are we looking at more than one condition, or is there another reason, do you think, that not everyone responds?
That perhaps everybody responds, or a high proportion respond, but if you have an extremely high risk, and the aspirin reduces your risk, you may still be left with a residual risk. David Wright looked at the results from the aspirin trial, and he said that aspirin does not kill off the potential of developing preeclampsia, but it shifts the gestational age at which you do get preeclampsia. So if you are meant to get preeclampsia at 38 weeks, then it shifts you to a preeclampsia at 43 weeks, and therefore you don't get preeclampsia. But if you are meant to get preeclampsia at 37 weeks, it shifts you back to getting it at around 40 weeks. And that's why the incidence at term does not increase. But if you are meant to get preeclampsia at 28 weeks, and you have a big shift to the right, you may arrive with preeclampsia at 34 or 35 weeks. We don't really know, Steve, and I don't like to speculate too much. Everybody likes to produce different theories of how aspirin may work. I honestly do not know how it works.
Thank you. And that also answers Huda's question as well. So thanks very much. So let me open to the other panelists. Yeah, Basky.
Hi, Kipros. This is, I completely agree with everything you say. This is not to challenge the data and the evidence at all, but just for, the 1,000 people online who are sending you kisses, love hearts, and all this sort of thing.
They're for you, Basky. They're for you.
Yeah. Just a couple of things. So I know you don't mean it, because in the aspirin trial, not only did you give aspirin, but there were scheduled scans at 2 time points. So we often say, we do the risk scan just so that we give aspirin. But can you confirm that, we're looking for a uteroplacental disorder, which not only increases the risk of preeclampsia, but also fetal growth restriction and stillbirth. And therefore, it is not just giving aspirin, it's giving aspirin and making sure the woman has some serial scans to monitor for early onset fetal growth restriction, the risk for stillbirth.
I think that on the point of the fetal growth restriction, you're right. And when you are the editor-in-chief of the White Journal, you encouraged me to look and publish the data. Aspirin not only reduces the risk of preeclampsia, but also severe early onset fetal growth restriction before 32 weeks. So it is true that would be the case. In the trial, we had set visits, but the main reason for the visits, Basky, was to ask the women if they had any side effects. It was part of the protocol, and whether they were taking their tablets, rather than specifically following them up for growth. But I think that we should be assessing the growth and the development of preeclampsia in these women anyway. So you're right in that respect. Yeah.
Fantastic. I think it's an important message, Kipros, because people walk away. I've seen many units now in Europe which just do preeclampsia screening, give aspirin, and send the women away with no cognizance of the fact that we are screening not for placental dysfunction, and that preeclampsia is just one of the symptoms. I suppose the next one is a much more controversial one. Leona's published a study in Circulation a couple of months ago, and rather unfortunately, I see it as a potential problem. Do you see the results of Leona's study as a concern?
Yeah, a bit, but you can carry on.
Well, I think the thoughtfulness and the design of the study was such that it was designed to fail, such that they showed overall no difference in the incidence of preeclampsia overall, which was going to happen given the way it was designed. And the focus of the primary outcome should have been the incidence of preterm preeclampsia in the high-risk population, which is exactly what you've shown in the aspirin trial. Do you agree with that?
Yes.
Okay, thank you. I think I should give the other panelists a go while I
have maybe, I don't know if you have the ability, Steve. Maybe Leona is in the audience and she wants to say something.
Great, thank you.
If we can find a way.
I was hoping that would be the case because she doesn't
I'm
sleep.
sure that you did it deliberately. Yes.
Right, so I can't do that. I don't know whether Daniela can do that because I don't have control. But maybe we'll take other questions. There's quite a lot of online questions as well, so I can pick up some of those. Daniela, do you?
Yes, I've allowed Leona. I think she's able to talk now.
You start,
Okay.
Leona?
That's very strange. Anyway.
We can hear you, but we are missing you. So you're hiding, but you can.
I'm not allowed.
You are.
So-
We can hear you.
No. Well, you can't see me.
Oh,
That's okay. Just say.
I mean, the thing is, though, while listening to this conversation, it's like I want to. Ask whether there are concerns. So Kipros didn't actually say what concerns he had. Perhaps you can clarify, please.
He did, Leona. But anyway, Leona, I don't know if you can hear us, but
she will.
Yeah,
respond
I just because it was very, very brief, and then it would be nice to know because
I think let me read.
Yes, there were concerns, and well, please explain not to leave it for the audience to wonder what's happening, because after all, 42,000 women participated in the study, and if there are concerns, I think all the audience ought to know.
I think you may have missed it because I did highlight the issue, so I'll re-highlight it for you again.
Yes, that would be fantastic. Thank you.
Yeah, so if we had our time again, I suppose, would you have done the trial differently, Leona?
Oh, no, I think the intention was not to do a conventional randomized trial because we already did it with the Asprey trial. The intention was an implementation trial because people really do want to see real life data from bench to bed. There is an absolute lack of implementation research whereby, yes, it's fantastic to see these beautiful randomized control trials and seeing the positive results, but then if you realize that following a successful randomized trial for clinical implementation, there's still a massive gap. And therefore, the purpose of my trial was to do a randomization trial. The only issue that I had was because of COVID. As you remember, we were meant to screen 68,000 women to prove an absolute reduction of about 2% based on the Asprey trial results. But because of COVID, and it's either we pause the trial for 3 years, and hence we wouldn't have been able to do the trial at all, or to go ahead and to continue and suffered as a result of COVID. And therefore, we actually recruited 2/3 of the cases. And therefore, yes, you're right. We anticipated the primary outcome to be insignificant because of the under recruitment, and therefore we accepted that limitation. And so, yes, it was not designed to fail. However, because of COVID,
perhaps
we basically, yeah.
Let me rephrase the question. Would it have been better to have put the incidence of preterm preeclampsia in the high-risk population as the primary outcome? Would that not have been better in retrospect? Do you think that would have had a better outcome?
No, it was a decision that we made with our trial statistician that because of the design of a step wedge, which is obviously quite an uncommon design for now because it's a new kind of study, and so we took the advice of our statistician, and basically because of the under recruitment during the COVID pandemic, and that it was difficult to change the primary outcome, and because we already more than 2/3.
I think we should agree to disagree, and we can talk about it another time.
Okay,
I'm going to the other attendants.
I'll go to pick up with the other panelists just while you're thinking. Okay, Ranjit, you go. There's quite a few questions online which I'd like to pick up with you, Kipros, if that's okay. Ranjit, do you want to go first?
Yeah, Prof, amazing lecture as always a pleasure. Prof, you've showed a lot of data that there's so much of evidence that screening for preeclampsia using the combined model is the most effective way to screen. Of course, it's still not universally adopted by professional bodies, but there is so much of evidence from not just the data from England, from the multi-center studies that have been carried out here and the RCT, but also from Spain, also from Denmark, and also from various places. The clinicians and the academics and the skeptics who still express concern about screening for preeclampsia, is the matter not the issues that you highlighted about the quality control? So people who demonstrate lack of effectiveness of screening for preeclampsia, is the issue not training in uterine artery Dopplers, appropriate measurement of blood pressure, and quality control for PAPE that will actually improve the screening in places where they don't find effectiveness? And whether those populations where they don't have a high detection rate should actually modify and adjust their screen positive rate, as you highlighted that it is different depending on the population you study.
Exactly. I fully agree, Ranjit. With any method of screening, we need to have a background of quality control. And that has been shown so perfectly by the system in England. Every few months, we will receive a report from David Wright and his group that some of our people are not measuring the nuchal properly. And then we have to, we have to retrain them. And the same with the biochemistry. The biochemistry keeps changing all the time and with different lots. So unless you adjust your values, then there is a risk that you will get unreliable results. In terms of the uterine artery Doppler, although we say it is easy to train people, it is not necessarily the case with the uterine artery, but it is much easier to do the ophthalmic artery, much easier.
Can I pick up on the ophthalmic artery, because there's a lot of questions about that. People are asking when exactly should they do it, the validation of it, what cutoffs they should use, and how do they actually introduce that into clinical practice? Are we in a position where we can do that at the moment? So if you could just talk a little bit more about the ophthalmic artery.
Well, the screening is done at 12 weeks and 36 weeks for the two types of preeclampsia, and also at 20 weeks for readjustment of risk. The values are not, I'm always reluctant to give a specific cutoff because the cutoffs are dependent on different maternal characteristics. And I think the software, I have been promising that for the last year or so, but we are extremely close now. Within the next month, we will be releasing software that will be highly available, freely available to everybody in the world, so that they can enter the values and then the calculator will tell them their risk, 12, 20, and 36 weeks.
Brilliant, amazing, thank you. If I can